Dr. Aveek Jayanth for talking on pediatric cardiac patient coming for non-cardiac surgery, how to go about it.
I was, stuck with this. This is entitled "What is New." So what I'm going to actually do is I'm going to find a new way of saying old things, and hopefully that will work. I thank the organizers. I'm not a full-time pediatric cardiac anesthesiologist, so that's an admission. Okay. So I have two disclosures that I think I should make because you have a postgraduate audience. I largely teach subspecialty anesthesiology, and I don't think it's such a big deal at all that you do subspecialty anesthesia, but I find increasingly students are unprepared because it's like we're asking them to sing difficult music when they don't know basic music, right? And this is also for the teachers in the audience. I think it has a lot to do with the way we teach people anesthetics, especially in India. And remember that the hype that surrounds the perioperative surgical home in the US, the proponents feel is changing anesthesia education. So if there's somebody I should invoke, it's this great man who I straddle the anesthesia and the cardiac worlds. They're probably the best organized society in India that owes to Professor of Pediatric Cardiology in All India Institute because he literally mentored the subspecialty here. And this is something that he said which is really worthwhile for all of us to remember. Okay, so the first lessons that I thought, I want to engineer this for a non-cardiac anesthesia audience. So I think the first lessons are learning to sense danger and managing this better. So this is not a review of anesthetic considerations for congenital heart disease. It's not going to prepare you for an exam, ask you how, your examiner might ask you how do you treat a dead spell. It's not about all that, okay? So I'm going to give you a functional assessment of congenital heart disease and I'll take a devious path to reach there. Okay. So that's where I begin. This is data from the anesthesia-related cardiac arrest registry, and it says the key thing here is if you have a child with heart disease and you're a non-specialist, your child is small, beware. Don't jump into anesthetizing small children with heart disease without adequate backup or knowledge. Okay, so children who have more than 50% are 6 months old, less than 6 months old. When they have heart disease, they're invariably very sick. So this is not an area for adventure. Remember, the cardiovascular disease is the preeminent cause of cardiac arrest in children. Okay, and this is a true story. This comes from a center which has pediatric cardiac anesthesia and pediatric cardiology. So we had this child, 9-month-old, very well awaiting palliation for univentricular heart. He was posted for a laparoscopic pyeloplasty. The attending anesthesiologist had every single detail, even electronic medical record. Procedure lasted longer than a normal pyeloplasty because the surgeon decided to do it laparoscopically. He needed emergency bailout by the cardiac team and was nearly dead. So that's what does it say about our system compared to any other system in the world? We are too confident of ourselves. And often the simplest mode of failure is lack of communication. It's not about lack of knowledge, it's about lack of communication. Okay, so now let's just sort of change gears. What do you think is wrong with this ECG? Again, my big qualm about anesthesia education, I think before I came here, I was at probably one of India's best centers for MD anesthesia training, and as far as I know, ECG training focuses on can you identify 10 ECGs which are put for the exam. But remember, you may be the practitioner who's actually going to read an ECG for the first time in an emergency situation. No, you're not taught to do this. So what is wrong with this ECG? This is an absolutely normal ECG in a patient who has situs inversus. I showed it to tens of anesthesia students and they can't identify it. Okay, so remember, so situs is important, not just about placing ECG leads, but also about fiber optic intubations, about placing central lines. So that's the first step in assessing. If you have this child with congenital heart disease, pay attention to situs and see what implications that can. So I intentionally put this very crowded slide. This is intended mainly for cardiac anesthesiologists. It's about one of the most extreme conditions with situs, which is heterotaxy. And you can see how many things can go wrong. So if you have a child with congenital heart disease, insist on detail, do not compromise. And yet, simple is beautiful. Any of you, can you identify this, where this is from? No? This is something that I read just before I wrote my Pediatrics MBBS exam, just to show people that I knew more than them. It was very foolish because I spent a lot of time just studying for the PG entrance. I knew all this, but it was of no use for the PG entrance. So this is from the Pearl of Clinical Recognition of Congenital Heart Disease. Whenever you encounter a child with congenital heart disease, these are the 5 questions that you ask. Okay, is the patient cyanotic? Is pulmonary artery, and you must ask them in this order. I'll try to explain why. Is pulmonary arterial blood flow increased or decreased? Does the malformation originate in the left or the right heart? Which is the dominant ventricle? And is pulmonary hypertension present? Okay, so are you less assured or more assured when you have a cyanotic versus an acyanotic child? Somehow there's no response. Are you more fearful of anesthetizing cyanotic or acyanotic children? And if so, why? Okay. So the first warning sign, if you've passed all the other categories, if you have a cyanotic child, remember this is especially applicable to neonatal anesthesiologists anesthetizing in an emergency. Remember there are 2 jinx circulations. One of them is transposition, the other is TA-PVR. The circulations are crossed. Do not try to touch them before you have complete data on how they are, because the only way you can diagnose this is echo, right? So if you have a cyanotic child, insist on morphologic imaging. You cannot do this like adult disease. You can do CABG, you can have patients with CABG taken up for non-cardiac surgery without any anatomic imaging. You cannot do this here. Okay, the next big question to ask if you have a cyanosed child is, are your outflow tracts in jeopardy? If you have right ventricular outflow tract or left ventricular outflow tract obstruction, step back. The reason is you may have duct dependency, which will manifest when you give hyperoxia. The duct will close, and that's when it manifests. Remember, it's especially tricky for left-sided outflow tract obstruction because the entire lower body flow will stop. You will have renal shutdown, lactic acidosis, gut ischemia, neck, everything. So this is the next question to ask. Is there a factor, then if you have a patient with cyanosis, is there any factor that is causing persistent fetal circulation? This is the tricky bit because anything, hypothermia, sepsis, all of these cause persistent fetal circulation. So these are the 3 questions that you have to ask before you anesthetize any cyanotic child. And remember here, the real trick is the brain is the heart of the matter. You are measuring peripheral saturations. If you deliver desaturated blood to the brain, nobody knows what is going to happen, nobody knows what is the saturation. So if you're a center caring for cyanotic children with low blood saturation, you cannot do this surgery in this era without near infrared spectrophotometry. Okay, what about this? I'll just sort of give you a tour. What about asking, is it the right or the left ventricle? Why are you interested in knowing whether it's right ventricle or left ventricle? The reason is the ventricles are actually in evolution. At birth, the right ventricle is probably the more powerful ventricle. So it's not so much of a question at birth, but as your PA pressures tend to decline with transitional circulation, the right ventricle tends to weaken. If it is the systemic ventricle, once it starts to weaken, any gross change in afterload, pain, IV injection can cause it to fail. So the 2 key things here, age at which you are assessing, and whereas the left ventricle. And once the right ventricle is regressed, remember as a take-home message, it's always very difficult to lift up a failing right ventricle. It's relatively easy to pull up a failing left ventricle. This is especially true of settings like India where extracorporeal circulation, even if available, how many patients can you afford to put on ECMO? Hardly any. So when financially constrained, your evidence has to be, your knowledge base and your approach has to be perfect. So even if you were to have it, cannot offer it to most patients. Okay. The second big thing is, do you actually have two ventricles? Suppose you were to have one ventricle. What does it mean to you? Very basic common sense. See, you've one pump working in the place of two pumps. So it's actually working two circulations. It cannot be normal, right? The second big thing is, this pump, which is a systemic ventricle, eventually will have to last as many years as it can. So any loss of myocardium, just like say ST segment elevation, myocardial infarction is gone. So you have to protect the heart, but you have a heart which is actually pumping two circulations. Second thing is, in assessing a ventricle, you have to put it in the perspective of the physiology. So you know that Eisenmenger for you is inoperable. But the Eisenmenger right ventricle, for example, is actually quite good. It's a myth that people with Eisenmenger die. They die younger than you and me, but the ventricle is tough because it's used to high pressure work. So it's not going to fail in a hurry. This is not true of idiopathic pulmonary artery hypertension. If you have it, it's evolved over 1 or 2 years. The right ventricle will fail at the slightest pretext. In Amrita, before they started doing obstetric anesthesia in conjunction, we have had one patient with IPAH die while doing a cesarean section. Since then, just that fear of a death has got everybody together. It doesn't happen anymore, although we do sicker and sicker patients. Okay, so important thing to realize here, if there is a take-home message, is avoid any sudden increase in afterload. It's just, if you want to remember the physiology, it's just like how you would treat patients with coronary ischemia. As somebody told you, the biggest risk factor for PMI, perioperative MI, is not severity of coronary artery disease, but afterload mismatch, like demand-supply mismatch. Okay, so same thing can happen here. Suction, pain, all of this can cause the ventricle to fail. So is the PBF normal or abnormal, right? You can get cyanosis with increased pulmonary blood flow because of shunting. So this is easier to make out clinically. Does the patient look dry or wet? And very, very important, we have had one patient where a master cardiologist at our center has revised the entire treatment plan based on chest X-ray, not based on the echo. He saw something in the chest X-ray which suggests that despite child having pulmonary stenosis, the pulmonary blood flow was actually increased. CAT shows pulmonary artery pressure of 150, suprasystemic peer pressure. So simple things make a difference. If the PBF is low, which means it's dry and patient is cyanosed because of low PBF, remember the major risk factor here is anatomical constraint. Very small right ventricular outflow tract. This cannot be medically managed. So don't jump the gun. Until you are secure that there will be some support for you. It's just like if you take a patient for mitral stenosis for surgery, there's no way you can medically open the mitral valve. The only way is surgical or CAT. Same principle applies here. If the PBF is high, then you can modulate it by changing the ratio of pulmonary vascular resistance to systemic vascular resistance. Now, pulmonary vascular resistance, as you know, can be modulated, increased by decreasing oxygen content and increasing carbon dioxide content. Okay, so these are some of the principles that you will use, but don't forget, if there is an anatomic constraint, step back. Okay, these are things that you already know, and this is like an interlude. What about management of anticoagulation? Here I would like to point out to you that all of the evidence that pediatric cardiac anesthesia perforce follows is largely from adult cardiac anesthesia because of the paucity of trials. Remember management of hydration for hyperviscosity, because if you have a child with high hematocrit, this fasting for surgery can trigger stroke. What about laparoscopy, as those guys have done? It's possible to do anything, but provided you know what is exactly going to happen when you insufflate carbon dioxide to the circulation. This is something now, again, related to anesthesia education. People are taught about workstations, everything. So ask people, do you know what is the accuracy of a pulse oximeter? And everybody looks at me as if, this is a question that's of no relevance. So every pulse oximeter has an operating range and an error. When you care for these children, you must know how well they work. If the saturation reads 70, it's not 70 because pulse oximeter is not calibrated to read 70. The usual operating ranges for most pulse oximeters are 81 to 100 with an error of plus minus 2 or 3. So technical literature important. What about cerebral saturations? This is not evidence based. When you are in trouble, remember crux is cerebral blood supply. People are taught here CO2 management is very important because neuroanesthesia, if you try to drop their CO2, the blood going to the brain is very low in saturation, cerebral vasoconstriction will occur and you will actually cause more harm. Okay, this I will not. Okay, what about somebody, I think my previous speaker spoke about filling pressures. So this is something that you want to know. Does your central venous catheter actually show the filling pressure of the systemic ventricle? So if you have an ASD or a non-restrictive VSD, CVC shows you the left-sided filling pressure, right? Because there's no constraint. Every heart is one big chamber. So that's the importance of understanding the echo. I'm not going to go about this. But this said, remember that the CVC or central venous pressure is antiquated to use it to titrate fluid therapy today. However sick your patient is, or however fluid, unless he is dying and CVP shows 0, it has no meaning, right? Okay. So what if you don't want to remember anything, what is it that you must remember? Never ever care for children with a single ventricle alone. Because they are the guys who are most vulnerable. If you're doing it for the first time, step back. Say, I want cardiac anesthesia cover, I want somebody else to do it, somebody more adventurous. So that's, if at all there is this, what are the patients who are easily anesthetized? Those are the patients who have unconstrained outflow tracts and left-right shunts. Okay, I'll work. Okay, so I'll just go over this because this is the order of deaths in the pediatric cardiac anesthesia registry. I will not go so much into single ventricle because I have only 3 or 4 minutes left. Okay, there are scores to predict this. What about venous access? Does anybody remember this from your anatomy? No, we don't know because anatomists don't teach us. Why do you need to remember this? But remember, when you have congenital heart disease, you have 60% more chance that your veins are not normal. Okay, the very rare situation is where you don't have a right-sided superior vena cava. So if you don't know this, you can keep trying to put a right IJV. It will never go anywhere. Okay, so that's the important thing to realize. Why everything is important here. Okay, you can have a persistent left superior vena cava, in which case, if you put a left-sided IJV, it will lie in the coronary sinus. You can't keep a catheter in the coronary sinus because the coronary sinus thrombosis will have sudden cardiac death. Okay, this is another thing that I thought, if you forget everything. I ask everybody, including people who are doing MD in my institution, if given a choice, you're given an ultrasound probe and you're asked to put an IJV, will you do it with the ultrasound or without the ultrasound? And the usual answer is, I want to try it without the ultrasound because I may go to a location where there is no ultrasound. Fair enough, but remember, this is a smart ass answer. And if you land in trouble, there is no solution. In the era that is today, if you are in a referral center, you cannot put any IJV technically without an ultrasound. I continue to do it, but for the purposes of a lecture, you cannot do this. The single most important reason is the IJV is not constant in position relative to the carotid artery, right? You can see that group 2, 22% of patients actually have the IJV and the carotid artery overlying each other, okay? So I'll skip all this because it's not important, but everybody seems to say femoral lines are very easy. No. If you have an interrupted IVC, the femoral line may actually lie in the paravertebral venous plexus. You give inotropes, people can get paraplegia. So in this territory, there are no rules. Every rule is meant to be broken because every anatomic subtype is different. Okay, I'll skip all of this because it's not important. So this gets us to the core of this thing. What if you have a left to right shunt? I will skip this and the slides are with him so you can go through this. But it's not so difficult. Okay, so any left to right shunt, what is the importance to the anesthesia provider? Is one simple thing. What level is the shunt? So if you have an atrial level shunt, these are small volume shunts. You're unlikely to get pulmonary artery hypertension. This could be done by your JR and you can be sitting and drinking coffee. Nothing will happen. Okay, so that's how simple it is. However, as you go towards the ventricle or the artery, the shunts tend to get bigger. The chance of you having pulmonary artery hypertension is higher. And as you go to the arterial level shunt, there is a big trick here. Coronary steal can occur. You turn up the oxygen, diastolic and mean blood pressure falls, all the blood will go to the pulmonary circulation, and there will be coronary steal and arrest. You can't revive them. Okay, so the more distal your shunt is, the trickier they are to manage. That's all that there is. Then there is this quirk that everybody says maximize the PVR, right? To reduce the level of the shunt. But the key thing here is, can I take 5 minutes more? Okay, so the key thing here is, this is on the basis that pulmonary artery pressure is always flow related. Twice the cardiac output is going into the pulmonary circulation. That's why there's a rise in pressure. So it makes sense to increase the PVR. However, if you have a failing right ventricle, don't try this. Because it's like ventricles are already huffing and puffing. If you raise the PVR by causing relative hypoxia, the RV will fail. So if you have a big level shunt at the artery or even a VSD, the key situation is what is the status of the right ventricle. If it's abnormal, be careful, don't suddenly increase the PVR. Small changes in preload, such as with bagging, can make a big difference. So how you anesthetize these patients is critically dependent, dependent on the size of the shunt, and not on the PA pressure, but on the size of the ventricle. Okay? That's a crisis that's dreaded. Not going to go into details, but can happen. Okay, sort of said all this. How do you prevent RV at crisis? Traditionally taught, all noxious stimuli, deepen anesthesia. Okay. What happens when you encounter Eisenmenger syndrome? Remember, in this era, all of them are on targeted therapies. So it's important to consult a specialist and make sure that they are receiving them. If your center does not have nitric oxide, do not offer patients the possibility of surgery at your center if you want to be 100% safe. Should they have a problem, the only bailout option may be nitric oxide. If you don't have it, don't do it. Okay, what about obstructive lesions? 4 or 5 things. They are fixed cardiac output states. They often have pulmonary venous hypertension. So when you put them under an anesthetic, usually things get better. The reason is, when you have a failing ventricle, I'm talking faster than I can think. So when you have a patient with a fixed cardiac output syndrome, always remember that there's no way you can increase cardiac output other than by increasing the heart rate. If you increase the heart rate, you may precipitate coronary ischemia. So key thing here is to maintain SVR. Remember, if they have ventricular function compromise, they are on the flat part of the Starling curve, so fluids don't matter so much. This is a rare case, but if you ever encounter this, it can cause sudden cardiac death. This is due to mechanical coronary artery ischemia. Okay? I'm not going to go into all this. Final thing is about cardiomyopathy. So if you have a patient with end-stage heart failure, how do you anesthetize? Are you really worried? What are the key goals? Can you just give me 2 or 3 things and then I'll stop? Okay, skip all this also because this is too much for all of you. Okay, so I just skip all this because I'm very keen that I'll finish on time. So, if at all there is a key message here, it's very simple. Do not do this if you don't have background information. Ask for help when needed and have a clear backup plan. So, we have to get out of this fixity that every case can be done everywhere. It's nowhere true anywhere in the world. The only cases that can be safely anesthetized by non-cardiac anesthesia practitioners are when you have left to right shunts which are not at the arterial level, when there is pulmonary artery hypertension but the right ventricular status is good, when the outflow tracts are unconstrained. All other cases, ask for help. If at all you learn this, it's enough. Because there's nothing more, you don't need to, this is just like cookbook medicine. You can, if you're really keenly interested in doing this, you can learn it on the way. Don't learn it on a patient, we tend to do that. Okay, and this is to end with French philosopher who said, this sums what I learned from anesthesia. When I did it as a second option to medicine. And I thought, There's nothing in it. You know, people just put tubes, they put lines, and it's all done. But actually, because nobody teaches you, you have to learn every day. So you have to, before you start your anesthetic, you think I'm going to do all this, run all this in your mind. That's what the orator said yesterday. But when you work, also think, don't work mechanically. Don't work like a thinking mind. When you think, work like as if it is going to be active. Because if you're not good at putting arterial enzymes, so you're going to put 24 gauge in a 1.5 kg infant, it's not going to happen, right? So everything that you think must be executed, and every act that you execute must have thought. Because nowhere is this truer than in this branch of anesthesia. Okay, so if there are any questions? Sorry, I exceeded 5 minutes.
Thank you, Dr. Aveek. There's a shortage of time. I can ask. In fact, I'm very happy that you point out where to draw the line, because all cases of congenital heart disease cannot be dealt with by all the anesthetists. But I'll take one question because we are running short of time. I just want to make a point. Just one point, because you said about in this era where ultrasound has to be used. In fact, what I differ from that, because in our country, most 50 to 60% of the places still do not have ultrasounds. So my students, I train them for the first 3 months using landmark techniques where I stand by, and then ask them to use the ultrasound. That's the only difference I would like to say.
Yeah, I fully agree with you. I think functionally that's the truth. But I will relate to you one case after which I am terrified. We had a patient who's 79 years old coming for a dialysis catheter. She was on the last legs of her life. Somebody put the dialysis catheter just as you suggested. And she came to me, I was in CMC Vellore, her entire carotid artery had dissected. The only reason, scientific reason to suggest this is up to only 60 to 65% of patients have a normally related carotid artery and IgA. Anytime the overlap between the carotid artery changes in relation to, see the IJV overlaps, you know that, sir. So anytime this is different, there is no way to make this out clinically. So that's the only, it sort of sticks in my mind that even now in Amrita we're putting line. We've had an incident where a person who's finished a DM put the pulmonary artery catheter sheath in the carotid artery. And I went through the literature to search what to do, and every single person says the only recovery that has been assured is if you take them up for interventional radiology. So I think as a take-home message, I am...
It's experience that teaches you. Thank you very much. Thanks a lot.